Hey, BC here. Welcome to BC Nephro. Thanks for watching. Today we're going to talk about the next subject in our dialysis rounding primer series, which is mineral bone disease. To check out the full playlist, there'll be a link in the description below. Also, you can learn more at bcnephro.com. The link to that will be in the description below as well. So, mineral bone disease. What we're talking about is management of phosphorus, calcium, and PTH. So what happens in kidney failure and end-stage kidney disease? So there's a couple things that the kidneys normally do that they can't do and that we have to treat for in dialysis patients. The first thing is the kidneys excrete phosphorus, the main way that phosphorus is removed from the body. So when phosphorus is not removed from the kidneys, what happens is the body tries to compensate by increasing the PTH, parathyroid hormone level, and by increasing something called FGF23 in order to stimulate the kidney to excrete more phosphorus. However, this doesn't work because the kidneys don't work. So the levels go up, phosphorus excretion remains down. The second thing that the kidneys do is they normally activate the vitamin D stores to the active form. So they take the 25-hydroxyvitamin D and via the 1-alpha hydroxylase, they form 1,25-hydroxyvitamin D, which is the active form called calcitriol. And so in kidney failure, that process is impaired. When you have low 125 vitamin D levels, you have less calcium absorption through the gut, tendency toward hypocalcemia, and the body compensates also by raising parathyroid levels. So kidney failure, you have hyperphosphatemia, high parathyroid levels, and also high FGF23 levels. So this causes problems. So first of all, hyperphosphatemia leads to vascular calcification, and there's an increased cardiovascular mortality, certainly with phosphorus levels greater than 5.5 for a prolonged period of time. The elevated parathyroid levels also cause problems. The elevated parathyroid levels act on the bones to try to maintain the serum calcium, and this causes bone disease. And if left unchecked, it causes something called osteitis fibrosis cystica, which is a renal metabolic bone disease. So in dialysis patients, it's important to regulate these things. So the first thing you're looking at is you want to regulate the phosphorus. Now, dialysis does remove phosphorus, but it doesn't remove enough phosphorus to keep the patient in a neutral balance. So the patient's going to be a positive phosphorus balance and have hyperphosphatemia. Now, daily dialysis or extended dialysis, nocturnal dialysis does a better job, but the traditional 3 times a week dialysis is not going to be sufficient. So the second thing we have to do is talk about diet. There's certain foods that have a lot of foods have high phosphorus in it. Some of them are high protein foods, which are good for the patient. One of the things we counsel the patients to stay away from, and some of the big things are dairy products and dark sodas or colas, which are preserved with phosphoric acid. And it does turn out that the phosphates that are preservatives have higher bioavailability and are more absorbed than the phosphorus in natural foods. A healthier diet in general with less processed foods is going to help this as well. Unfortunately, diet is not sufficient as well, so people need to take, dialysis patients most often need to take phosphorus binders with their meals to impair phosphorus, bind up the phosphorus in the gut and impair absorption. So there's a number of different categories of phosphorus binders. Now, the first one traditionally years ago was aluminum based. Now, aluminum does bind the phosphorus and was used as a binder. However, it caused aluminum toxicity in dialysis patients, which ended up causing some serious problems, bone disease, osteomalacia, anemia, and could even cause dementia. So we've moved away from aluminum-based phosphorus binders. Can be used very short term, but not chronically because of this problem with aluminum toxicity. Now, the thing to know about aluminum toxicity is caraphate, which is sometimes used as an add-on for GI ulcers. That has aluminum as well. So if you have a patient who's on caraphate, you're not going to want to use that long-term as well because there's concern about aluminum toxicity, and you're going to want to check the phosphorus levels because it might be acting as a phosphorus binder. So the next class of binders is calcium-based. Now, typically, the binder used is calcium acetate, which goes by the brand name Phoslo, as opposed to calcium carbonate, which is what is seen in Oscal and Tums. It is purported that calcium acetate binds the phosphorus better than calcium carbonate. It may also be associated with increased GI side effects and less well tolerated. But in any event, that's calcium acetate is what's typically used. However, if the patient's in a pinch, says they can't get the binder, they don't have the prescription, is not covered, I suggest that they substitute either Oscal or Tums instead. Now, the problem with calcium is it can contribute to a positive calcium balance, and along with the phosphorus, contribute to vascular calcifications. So we want to limit the amount of calcium binders as well. So now there's 4 non-calcium, non-aluminum based binders. One is a sevelamer, which goes by the name of Renvela. Another one goes by the brand name of Phosphorinol, that's lanthanum. The third one goes by the brand name of Auryxia, that's ferric citrate. And the fourth one goes by the name of Velphoro. Once there's a high pill burden, there's GI intolerances. Some are chewable, some come in powder forms. So you really have to work with the patient to try to find one that they can really get in the routine and be adherent with. All right, so now that's about phosphorus. Now the next thing is about calcium. Even though the calcium tends to be low in many dialysis patients, there is a positive calcium balance, so we want to be careful about trying to give extra calcium. Now, in some cases, you may need to give extra calcium specifically after a parathyroidectomy, which I'll talk about a little bit later. But you want to prevent the calcium from going too high, and you want to tolerate mildly low calcium if it's asymptomatic. The calcium dialysate bath typically is 2.5, which can maintain a neutral calcium balance. There is a 3.0 calcium bath. I really prefer not to use a higher calcium bath unless there's symptomatic hypocalcemia, such as after a parathyroidectomy. Now, the calcium level, we want to keep the corrected calcium level less than 9.5 to prevent this vascular calcification deal. Some dialysis patients will have a tendency to a hypercalcemia. The hypercalcemia often is iatrogenic. Some of the calcium-containing phosphorus binders, some of the treatments for the hyperparathyroidism, the secondary hyperparathyroidism can cause that. And also, some patients can get what's called a tertiary hyperparathyroidism, which I'm going to start talking about in the parathyroid section. So then the third thing, so we have the phosphorus regulated, calcium regulated, and now we're looking at the PTH. Now, the thing about the PTH is it's actually supposed to be a high in dialysis patients. You don't want it super high because that'll cause this osteitis fibrosis cystica. But if you correct it to normal levels, you're going to actually impair bone turnover and cause what is called adynamic or low turnover bone disease. So the deal with the PTH assay is there's a target range which is supposed to be in between 2 and 9 times the upper range of normal. So we typically say in between 100 and 600 is a target PTH range for a dialysis patient. If you suppress it all the way to normal, you're going to likely cause low turnover bone disease. Now, the reason purported for this is that the PTH assay actually not only checks the active form of intact PTH, but also detects some of the inactive metabolites of parathyroid hormone, which accumulate in dialysis. Their clearance is impaired because of the kidney failure. So anyways, target PTH 100 to 600. So we got the phosphorus under control, we got the calcium under control. If the PTH is still high, we can take the following measures. One is to make sure there's enough 25 vitamin D. So even though the kidney doesn't have the 1-alpha hydroxylase, you do want to make sure there's enough substrate for this conversion to occur in the body. So you can treat with vitamin D, regular over-the-counter vitamin D, or prescription ergocalciferol to get your 25 vitamin D levels greater than 30. The next is treating with the active form of vitamin D, which is calcitriol, the active form of 125 vitamin D, which can be given in pill form, or an analog of this, which goes by the names of paracalcitol or Zemplar, or doxorcalciferol or Hectorol. And what they do actually is they act on the parathyroid receptor and suppress the production. Now, they have a tendency, because they're vitamin D, to increase the calcium, so you can have a problem with hypercalcemia, and they have a tendency to also increase phosphorus absorption. So if there's hypercalcemia or the phosphorus is too high, you may be limited about the use of these. So then the next agent is what they call calcimimetics. So calcimimetics act on the calcium sensing receptor in the parathyroid gland, and this is what normally provides the negative feedback. Hypercalcemia acts on the calcium sensor receptor on the parathyroid glands and suppresses parathyroid release. So calcimimetics actually stimulate this calcium sensing receptor to be active at a lower serum calcium. There's an oral form, which is called cinacalcet or Sensipar, and there's an IV form that can be given on dialysis. Etelcalcetide or Parsabiv is the brand name of that. So these are helpful in patients who you may be treating with a calcium containing phosphorus binder. You may be treating with a vitamin D analog, and they are getting some hypercalcemia. Now the move in dialysis is to be giving the oral pills for the vitamin D analogs, specifically calcitriol, or the Sensipar, or the IV calcimimetic in center. So this can help ensure that there's adherence, that the patient's getting the medication, and can be given 3 times a week. So that what can happen is the parathyroid gland is stimulated because of the hyperphosphatemia, the hypocalcemia, and what can happen with time is that can go from secondary hyperparathyroidism to what is called tertiary hyperparathyroidism. So what happens is these parathyroid cells get upregulated. They can become a bit autonomous, and even if the calcium level goes up, they can still be secreted, and you can get some hypercalcemia. So this is what's referred to as tertiary hyperparathyroidism. In these patients, using the calcitriol or vitamin D analogs is going to be a problem. You're going to be trying to use the calcimimetics here. In some cases, if things are out of control, you have to have a parathyroidectomy. So you would have the 4 glands removed by a surgeon. It is difficult because patients get hungry bone syndrome. After this, the calcium gets reabsorbed into the bones, and they can get very severe, life-threatening hypocalcemia. And there actually is a pretty significant mortality in the 30 days and year after a parathyroidectomy. In my opinion, some of this has to do with hypocalcemia and arrhythmias. And the issue is the people who end up having issues with this uncontrolled hyperparathyroidism that needs the parathyroidectomy, non-adherence with phosphorus binders and diet probably contributed to that. So here you have a patient with a history of non-adherence to diet and phosphorus binders. That's what put them in this boat to begin with. And then after a parathyroidectomy, they're going to have to be taking a lot of calcium and a lot of calcitriol to prevent life-threatening hypocalcemia. So you're putting a patient who may have a history of non-adherence in a situation where non-adherence can be life-threatening. So that's a very important consideration there. So that's it, the talk on mineral bone disease. Check out the link at bcnephro.com for an article on this. And if you made it to the end of this video, hit the like button, subscribe, let your friends know, and until next time, thanks for watching.